everyone, and welcome to today's Public Health Ontario's Rounds presentation on a public health perspective on supporting infant and early mental health promotion, the optimal opportunity for health promotion. My name is Sarah Carsley, and I'm Applied Public Health Science Specialist at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I'll mention a few housekeeping items. Firstly, I'd like to state that as the moderator of this session, I have no conflicts of interest. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session, and a Q&A session will follow after the presentation. If at any point you experience technical issues or if you require CME credits, please email capacitybuilding@oahpp.ca. It is now my pleasure to present our speaker for today's event, Dr. Chaya Kulkarni. Dr. Kulkarni is the Director of Infant and Early Mental Health Promotion at the Hospital for Sick Children. Also known as IMP, it's a national organization which improves outcomes across a lifespan through translating and promoting the science of early mental health into practice with families during pregnancy, infancy, and early childhood. Dr. Kulkarni has over 25 years of experience in a number of leadership roles, including frontline service delivery, policy analysis, research, and curriculum and resource development. Prior to joining IMP, she was VP Parent and Professional Education at Invest in Kids, and has also served as Senior Policy Analyst and Researcher for the Office of the Official Opposition at Queen's Park. Dr. Kulkarni has an advisor to the Dolly Parton's Imagination Library and a member of the board at Gateway Community Health Center. Now it's my pleasure to hand it over to Chaya to start today's presentation. Welcome.
Great. Thank you so much, Sarah, and thank you for the invitation, and thank you to those who have joined. I will also just confirm that I have no conflict of interest. I am not receiving any financial support or in-kind support from a commercial sponsor, and also noting that there's no financial payments, including receipt of any kind of honoraria that is going to me or to infant and early mental health promotion. So one more. All the content in the slides today was peer reviewed to ensure that principles of scientific integrity, objectivity, and balance have been respected. And before I begin the formal part of the presentation, I would like to just do a land acknowledgement. So I would like to begin by acknowledging the land upon which Sick Kids operates. For thousands of years, it has been the traditional land of the Huron, Wendat, and Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. Sick Kids is committed to working toward new relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land in caring for children and their families. So I'm going to dive right in. I've listed the objectives for today. So just understanding the importance of early mental health on lifelong outcomes, recognize the system gaps in supporting infant and early mental health in our current systems, better reflect and consider the policies within healthcare systems that can better support infant and early mental health, and identify opportunities to actively better support infant and early mental health within the public healthcare system. So I like to start with this slide because this slide is really, this is the story that we want to change. And the dotted red line is the trajectory of a child who is in a stable home, receiving appropriate supports. Issues of food security don't exist. There's, reasonably good family harmony. And the solid black line underneath is the trajectory of a child who's in a far less stable home. And you can see that the difference between their development begins very, very early on. And so this is, for me, this is the narrative that we are trying to change with the work that we do at IMP. We know from the science that really infancy, and when I say infancy, really a focus on prenatal to the age of 3, but our work certainly goes up to the age of 6. So there is a robust body of science that sees infancy as pivotal to lifelong outcomes. And in many ways, this is low-hanging fruit. And I fully acknowledge that today I'm talking to, probably mostly the converted, and you understand this. So it's a far easier and less expensive investment to make early than to wait until children are experiencing challenges and difficulties. The science has also been really clear that it's the easiest period of childhood, of really our entire life, to actually influence brain architecture in those first few years. So, just some basic nuggets around brain development. It is the greatest opportunity to influence developmental outcomes in those first 3 years. It's also a period of profound development in the brain that's unmatched by any other period of time in our lives. So every second in the brain of a very young child, you will see 1 million neural connections being made every second. And to me, that translates to 1 million opportunities to influence the child's well-being. However, we also have to acknowledge that these early experiences can have both a positive and negative, and a very decisive effect on how the brain is wired. So even if we can share this knowledge with practitioners, with colleagues, and with parents, caregivers, I think it helps us to just remind everybody how important these first few years are to a child's well-being. And what we also know is that when young children are very focused on just getting basic needs met, those are the neural connections that actually become very strong. So if I'm always worried every day about whether I'm going to be hungry, my connections around food, and getting access to food are the connections that become very strong. But that's, as a result of that, other connections like learning language, learning to read facial expressions, among many other things, may not get used and may not develop as we would hope and expect to see. We also know that the brain's ability to change in response to experiences is greatest in the first few years of life and goes down pretty gradually, but we see in this graph, it's a steady decline. And as that declines, the amount of effort required to actually support change is going up. So this inverse relationship really should be, in and of itself, a call to action for us to look more closely at what we're doing to support infant and early mental health. And we also know that when we invest dollars in programs in the early years, we actually get a much greater return on the dollars invested because a child has their entire life ahead of them. So I want to just set the context for you in Canada. So in other jurisdictions, so I would point to the UK, Australia, even the United States, infant and early mental health is a well-established scope of practice in many parts of the world. In Canada, it is an emerging scope of understanding and practice. And many efforts in Canada have really focused on the physical health of children and school readiness. And just based on the science, school readiness work tends to begin as children are closer to actually starting school. So we've missed that optimal period. And we also know that infant and early mental health is not covered in depth in most of the helping professions, right from physicians to social workers to many others. And we've just actually completed a survey among primary care practitioners, who have basically said they receive very little training in their pre-service programs around this. So how are young children in Canada doing? Well, in 2019, Charlotte Waddell found that 18 to 21% of Canada's toddlers and preschoolers present with some type of social vulnerability upon school entry. So that's a pretty significant number. Exact current figures are not available, and this is part of the gap because we actually are not gathering this information across Canada or even across Ontario. Current data from the work that we've been doing suggests that these numbers have certainly not decreased. And I want to point out that these numbers were pre-pandemic numbers. And we all know that families with young children were actually struggling quite a bit during the pandemic, and were struggling even to know where to ask for help, where to get their questions answered. And research also suggests that babies born during the pandemic may be at a greater risk for developmental delays. And certainly the data we're collecting on developmental status is indicating that, in fact, we're seeing a very significant increase in risk for developmental delays. In one community in particular, the risk had gone up to 40%. And I don't think any of us would be comfortable or find that, a number that we would like to see anywhere. We also know from the early development instrument that is collected in certainly across Ontario, but many other parts of the country as well. Their data shows that 25% or more of kindergarten children are vulnerable in at least one area of development. And in fact, when they compared 2004 to 2015, that number had increased. So vulnerability had actually gone up, not down. And again, I'll point out we haven't got the most current data that looks at what's happened after the pandemic to really look at that as well. So I want to shift and talk a little bit about policy and practice and where does equity fit into this. So we all experience infancy differently, and there's no question about that. And what that really means is that while we may, and I hear this a lot, we have equitable access to resources, that does not necessarily lead to equity. So equity, equal access to support services and outcomes is really not enough. We need to be more inclusive, and in being more inclusive, being able to provide those safe, supportive spaces for the relationship, not just the child, the relationship, but recognizing that some kids may need more than other kids. So really supporting every infant to reach their potential isn't just about equitable access. It's about recognizing that child A may need much more support than child B, and that they should have access to that. So just again, stating equitable access does not guarantee equity for parents of their children and the developmental outcomes they experience throughout their lives. So what are some of the key drivers of inequity and exclusion in our society? So socioeconomic disparities, poverty is a very significant one, but even things like parenting capacity, geography, where you live, even in Ontario, it matters. My team does a lot of work up north, up around the James Bay coast, as well as up north near Temiskaming. And I can tell you that access to services in those parts of the province, it's very different to what is happening in Toronto. I live in the Hastings, Prince Edward County region, and I can tell you firsthand, we have huge challenges in terms of even just getting nurse practitioners or physicians to come here. So geography can make a very significant difference. So where you live, it does matter. And then political and social factors. So government policies that may or may not address, and even without realizing it, I think, perpetuate some of those inequities in infancy. So what else contributes to inequity? Well, developmental limitations. So, even the experience in utero that a child has and what they're exposed to, they have no control over the circumstances that they're born into, and they depend on adults to be their voice. Their needs may not be recognized and met. And there was a recent case in our province that involved a 3-year-old and a 7-month-old who had been left by their parents, by their caregivers, for 4 days, left alone in an apartment. And the baby died, and the 3-year-old is clearly has experienced very significant trauma. Their parent or caregivers were not able to advocate for them. And I'm not sure where the village was, right? Because, 4 days is a long time for a 3-year-old and a 7-month-old to be left alone. So they really are so dependent on us to be their voice and to be the safety net for them. For parents, their knowledge of child development, their capacity to be parents, are they struggling with their own mental health challenges or addictions that may interfere with their capacity to parent, as well as their ability to advocate. And, are they able to access resources that support developmental needs, that will optimize the child's development and well-being? And do they actually feel like they are part of a community and feel like they have a sense of belonging and inclusion? And then limitations in terms of practitioners. Training can be very expensive, and I will just share this with you. Other parts of the world are very critical of the West, because what they know is that um, we develop a lot of interventions in North America, in parts of Europe, and then we end up charging very high amounts of dollars for people to access that same training. So, that is a problem. Culture can also be a challenge, even the culture a practitioner brings to their work. Time limitations, as well as funding. Often when, we're looking at budgets, for some, the training line is the first place to start to cut back, right? Limited access to knowledge. So if they're not getting it in pre-service, when do they get it? How will they access it? And that will have a direct result or impact on limited skills, and even the limited range of programs and services and supports that they see as being important to offer to families. And then relevance in terms of research, relevance and reproducibility. So I'm not sure that it's about researching novel ideas, but researching things that are actually easily replicable within the systems that we have, recognizing the limitations that those systems experience, right? Involvement of those delivering services in the development of research questions. I'll be very honest, I don't think this happens enough. I think sometimes there's always a risk of researchers having a question, maybe a very good question, that they're interested in studying, and that's what they pursue. But really connecting with community, is this what you want to know about? Is this a question that you would want to be asking? And maybe it is, or maybe it isn't. And what are some of the questions that you actually feel are important to be answered? So, we tend to have a strong focus on community and family engagement in the work that we do. But even there, I would say, it's an area that we're continuously trying to strengthen, is that connection with communities. And then systems and allocations. So who and what gets funded? How are those decisions made? I know, for instance, there was a decision made fairly recently about some funding to support infant and early mental health, or infants and young children, that went to public health or public health agencies, so community health centers. And it was never clear how those funding allocations were made. And as you know, if I were in a community health center, I'd be asking that question: who gets what kind of funding? How do we ensure that that's equally accessible to people? And then, of course, the use and interpretation of the science and relevant data. Can we better embrace the science of infant and early mental health? What are the feedback loops for all the data that we're collecting? How are we feeding those back, whether it's from the people that we collect data from, or policymakers or other researchers? What is the loop to really utilizing what we've learned? Sustainability, so cost and resources needed. And again, this comes back to, we may have a novel approach that's really great, but if it's not sustainable, if it's cost prohibitive, that is going to create challenges. And then looking at legislation, and how can or does our legislation actually create a safety net for very young children who cannot speak for themselves? So again, just reminding all of us that the evidence supporting the need for equity and inclusion is actually very, very strong. And science has shown us that infancy is this unique period of development that is not going to be given to us at any other point in our lives. So now looking at acknowledging and addressing the gaps that exist. So what do families experience in terms of wait lists? they're misleading. So for people who are referring kids to wait lists, they may feel like they've made progress. I've put the child on a wait list. That's the next logical step. But what families have actually told us is they are left with no immediate relief at all. We are also hearing, and I'm just going to state this, I do not have any evidence to back this up other than literally hundreds of conversations with clinicians. Practitioners are sometimes misdiagnosing or misusing diagnoses to access funding. And that's a system issue, right? Because certain supports and funding for supports are only accessible with diagnosis X. And so, out of, I think, desperation and a real desire to help a child and family, that is where the child is rooted. And that decision is going to impact their life forever, right? The science of brain development is telling us we're missing this optimal opportunity. And with no immediate response, the brain continues to wire in a way that may, in fact, support the delay and not support well-being. And again, families are really left feeling that they cannot make a difference and that an expert must intervene. And I say that because, I would challenge us to think about what can we do for families while they're sitting on wait lists? What are the things that we can do, keeping in mind the issues around equity, the issues around inclusion? Current policies can be quite limited in terms of their scope. Often, what is out there is based on volunteer engagement. So even programs like Healthy Babies, Healthy Children, early on programs, these all are dependent on the capacity of the caregiver, the parent, to willingly engage and see the benefit in participating in those programs. There is no safety net for a child whose parent or caregiver may not be willing to participate in those programs, but would definitely benefit from involvement. And this can all be very overwhelming families, and often things like wait lists, especially, and just being able to navigate systems, families give up. They just give up and they say, I'm going to wait till little Joey starts school and then the school system can deal with this. So again, the science suggests we should have a much more robust policy approach that supports infant and early mental health. So while I've identified things that I think are gaps and some challenges that we're facing, I think there are things that we can begin to look at doing that aren't necessarily high cost opportunities. So these can increase confidence and competence and capacity. So really investing in some of that knowledge and providing opportunities for practitioners, clinicians to access some of that science around infant and early mental health, creating system of care pathways, which I'm going to share a little bit more information about in a moment, implementing developmental screening. We have now created a national database, and I'll share some information about that. And then collecting, analyzing, and utilizing data so that it actually does inform the work that we're doing, the programs that we're designing, the funding that we're allocated, all of those things. So push the science upstream to increase confidence, competence, and capacity. So create a shared knowledge base among practitioners that no matter who they are, physicians, early childhood educators, that there is this common body of knowledge that all of them have access to support the families that they're working with. In the survey that we've just completed, these are just, highlights of some of the results. So when asked about the training they received, what we heard is it was very, very limited. So most of them received less than a day of training in their pre-service programs. So the system of care pathways is work that is underway right now. We have a CIHR grant. We're working with 8 communities across Ontario. So when a parent or a caregiver or even a practitioner says, I'm really worried about, typically it's about the behavior or social emotional development of this young child, most people don't know where to go. So the system of care pathway is designed to guide children, youth, and families to, through, and hopefully out of care. It ensures that everybody is getting the right service. So they need equitable access to the pathway, but then once on the pathway, they actually need the pathway to recognize what they need specifically, the unique needs that they may have. So the pathway and creating these pathways, and I will, say quite honestly, my team is a really little team trying to do this work. I feel that this is work I would love for the province to really invest in, because families are struggling. The number of kids, showing up for school with challenges is increasing. So why build a pathway? Well, to build accessibility, to build a system that is easier to navigate for everybody, parents, practitioners, clinicians, everybody. It also creates a more equitable roadmap to help families navigate supports for early mental health. And the work that we're doing with these 8 community partners is really looking at what is in the community. So it's about leveraging what they have, because I can tell you right now, what is available, even in the region that I am in, what is available in Tweed, which is 8 minutes away from where I am, versus what is available in Bancroft is going to be very different, right? So really trying to work with whatever is available. So in Hastings, Prince Edward County, we had to actually come up with 5 different maps, because the geography meant that what was available was just so very different. A single map would not work. And the goal of the pathway is to really promote equitable access to infant and early mental health prevention, identification and treatment, and enhance community capacity to actually recognize the kids who may need or benefit from additional supports and services. This is what the pathway looks like. So we've shared this with the permission of the City of Hamilton. They're nearly done. We're working out some things with the pathway for older kids. So we have 2 pathways: birth to 3.8, and then they decided they wanted a second pathway that was 3.9 to 6, because once the school system is involved, things do change a little bit. So this was a couple of years of work to get to this place, and all sectors were at the table. And we're now in the process of actually developing family-friendly maps so that we can triage families to the right place. So in Hamilton, we want to triage them to healthy babies, healthy children. So the maps will hopefully help parents get to that resource in an efficient amount of time. And then also, I referenced data. We know very little about general development of children under the age of 6, and even less about children under the age of 3. And then when we look at social and emotional or mental health, we know even less. So current efforts largely focus on physical aspects like weight, mortality, head circumference, and diagnosis. Our understanding about how our young children are doing developmentally is limited. And we cannot answer the question, how are young children in Canada doing? And young is not under 16, it is under 3, under 6. How are these children doing? Compared to many other countries, Canadian children's health, let alone mental health, is routinely excluded in terms of children under the age of 3. We collect little information, and you can take a look at the UNICEF report card, which has a special report on Canada, and I'll just say that we do not do well. And based on available indicators, Canada actually poorly supports its youngest children. So this really means to me there's an opportunity for us to do more and better support outcomes for our youngest children. So we have established CANDDIS, which is the Canadian Database of Development Infancy to 6. It is the first Canadian database for children under the age of 6, and it spans the entire country. We implement this through REDCap, which on a server housed at Queen's University, because they are a partner. All of the information uploaded is de-identified, and our community partners who are part of this are using the ages and stages questionnaires. And then we also collect some demographic information from the family. And families have to consent to this in order for the information to be uploaded. And it really is a unique opportunity to see how children are developing in different organizations and regions across the country. Oh, sorry, my mouse is giving me a hard time. Okay. So what can we learn from monitoring early childhood development? And these are just examples of some of what we are learning. So in one particular county within Ontario, they have well over 2,000 records already entered into their database. And they're using this information to really look at children by domain, but also to look at various other aspects. So one of the things that they discovered was that children who were in home-based childcare appeared to be at greater risk for developmental delays compared to children in licensed center-based childcare. And so from that, what do we glean from that? We're not going to close or stop offering home-based childcare, but what we might say is there more we can do to support home-based childcare providers? What are some of the supports that we can, add to the work that they are doing with families? So we can learn a lot from monitoring early childhood development, especially if we can look at it, by different populations. So in this slide, we were looking at a child welfare sample out west, and what we saw was that children involved with the child protection system are at a much greater risk for developmental delays. And yet, we don't collect this data for kids in child welfare. How might this inform some of the supports and services in the child protection system? So just leading into my conclusion, look, actioning the science within the public health system. I'm going to come back to this slide because for me, this is the story that I know I want to change for young children. I really want every child to arrive at school ready to learn. And if we're going to do that, we have to be looking more closely at what exactly is available to families. And for families who may be reluctant to engage with those volunteer supports and services, it doesn't really make sense that it's either you volunteer, and if things really go wrong, the next step is child protection. What are things that we could do in between? Should we be looking at implementing developmental screening the way that we implement immunization, so that at least when a child goes to see a doctor or somebody within primary healthcare system, that a screen is being done, because a developmental screening can actually alert us to a child who may benefit from additional supports and additional services, as well as families that may be able to benefit. So I'll just wrap up by letting you know about a few dates. November 20th is, I think, a inaugural meeting, really the first of its kind. We've invited a number of people who are sitting on some kind of database for children 0 to 6. So this would include organizations like Can Child, our office, among many others. And the response to the meeting invitation, which has gone out, has actually been incredibly positive. So I think we're going to have very good representation from people who are involved in collecting data. And it is an opportunity to look at, who is doing what. Are there opportunities maybe for collaboration, but also where are the gaps? Is there information that we should be collecting, but isn't being collected by anybody who's in that space? May 5th and May 7th, I'll just mention that that's the conference that we do, Expanding Horizons, and that will be happening in Toronto. And public health has always been, you've always had really great representation. We know, and I know for me personally, if I have to point to where I think the greatest knowledge or strength in Ontario is around infant and early mental health, I would say it is within our public health system. I know that public health has made investments. So we always see lots of our colleagues from public health at that conference. But I think the other really big and exciting news is that we actually will be hosting the World Congress on Infant Mental Health, which will happen in Toronto, October 2nd of 2026. This brings almost 2,000 delegates from around the world to Toronto. I really hope it's an opportunity for us to showcase a lot of the good work happening in Ontario, in Canada, with colleagues from around the world. So this will be a very important event. It feels, for me personally, it's a little bit like the Olympics. So our team is already working away quite hard on preparing that. And I will just finish with this slide. So I'm a kayaker. I love to go kayaking first thing early in the morning before my day really gets started. And for anybody who's spent any time on the water, turtles are very sensitive to sound and sight. So usually as soon as you hit your paddle within 20 or 30 feet of them, they scatter, they're gone. And I came upon this group of turtles, and even I was so close. I mean, my staff are always teasing me that, really the resolution of this picture is not very good, Chaya. And I'm like, it doesn't matter, because the story it tells me is really beautiful. And this is what I want for every child. Every child needs a person who is so engaged and so mesmerized by them that no matter what is happening around them, that person is still there. And that's what I see with the bigger turtle in the middle with the little turtle. And no matter how much noise I made, they stayed there. And they were just enraptured with each other. And that is what I wish for every child, for every parent-child relationship. And I really believe that there's an opportunity for all of us, public health being a leader in this work, um, to really begin to look at how we can do things differently, to create that safety net, to create a space where every child is really and truly going to reach their potential, recognizing that potential will also differ among children. So with that, I will close, and there's a close-up of my little friends. Um, and I will say thank you, and I'll hand it back over to you, Sarah, for any questions.
Thank you so much, Chaya. That was really an amazing presentation and a wonderful overview of where we are in the 0 to 3 and 0 to 6 space around infant and early mental health. So we're now going to move on to the Q&A segment of this event to address some of the questions from our audience. So if you haven't already, please continue to enter questions into the Q&A pod, and I will get to them as they come in. I will take moderator's privilege, though, and ask the first question. Public health, since we came back from the pandemic, has been thinking a lot about where we sit and what our role is in, developmental surveillance, early mental health. And I'm not sure there's a clear answer. So my question to you is, where do you see public health's biggest contribution in developmental screening and early infant mental health as like a complement to primary care, screening pathways? Where should public health units focus their efforts if they had to
Yeah.
choose?
And honestly, Sarah, I think public health units are telling us this, because in every community where we are doing the pathways work, public health is positioned as a leader. And that's where I see public health. I think that even in terms of surveillance, public health should have a role in helping to implement, to create some sort of surveillance system that to some degree holds us all accountable, right? So we do need a measure, as opposed to something that's kind of open-ended. We actually do need a measure that helps us to know how our youngest children are doing. And I think public health is best positioned to actually guide the creation of that across the system.
Excellent. So our first question is, can you share the 8 communities that you're currently working with?
Oh, sure, yes. So we are 3 pilot communities were Hamilton, Simcoe, and Hastings, Prince Edward County. We've now branched out to include Kingston, Lennox, and Addington. And we're also beginning work with Moose Factory, Moosonee, Ottawapiskat, Kasheshawan. So those are our partners up along the James Bay coast. As well, we're working with in Simcoe, we have a separate pathway that will be happening around Indigenous children, because our partners there said to us that, while Indigenous families may be referred to mainstream services, they have many of their own services and supports as well. And they felt quite strongly that they should have their own pathway. So we're hoping to get that work started. And then as Hamilton, Simcoe, and Hastings, Prince Edward County finish off with us, and each of those communities, they will have at the end of the process their pathways complete, their parent-friendly materials complete, as well as an implementation working group that will go on forever, because pathways change. And so there has to be a mechanism that's actually built in to ensure that those pathways do change. We are also working with York Region, but they're not part of our CIHR grant. They've contracted with us separately to do the work on pathways.
Yeah. Okay, excellent. So our next question is, thank you very much, Trier, for that presentation. Would you please clarify, were all the home-based daycare centers that you studied unlicensed? Was the
No,
comparison?
I think they were. I think it was actually mostly licensed childcare, home-based childcare.
Okay, so the next part was the comparison home to center-based or licensed to
Yeah, it was
unlicensed?
licensed to licensed. So licensed childcare centers and licensed home-based programs.
Oh,
That's where they were comparing. Yeah.
okay,
And
excellent.
again, because system-wide, that's where they could get the ASQ completed, because those structures are in place, as opposed to the more informal home-based childcare that might be out there.
Yeah, and I do recall in some previous research I had done, there are various regulations of oversight on unlicensed, licensed, but even within the licensed world between centers and home base, there's different rules that might explain some of the differences between of the
Yeah.
quality, right?
Well, and again, it comes back, I think, to the differences in what is actually available in one community to another.
Mhm.
And I think we would be really surprised by some of the differences in what is actually available and accessible to families in different parts of the province. So one of the communities where we're working, um, there there's good basic level support for young kids, but there's no so let's think about this little one in Kingston who's had this horrific experience, right? I mean, this is a child who's going to need some pretty intensive repair. Let's just call it repair. And in the community I'm thinking about, there isn't capacity. No one has those skills at all.
Mm.
Uh, so that's a really big challenge. And I think there's also the risk of people, and not saying that's what happened in this situation, because our colleagues in Kingston are working really, really hard on their pathway. But there's always the risk that people feel that just putting the child into a foster home, that's going to fix things. And we know that infants do experience trauma, and it has a very lasting impact in terms of brain architecture and structure. There's a famous study called the Bucharest study, and what they found there was that when children experience this pervasive kind of trauma, and it isn't just about one bad event, it's much more pervasive than that. In their early years, they're very hyper vigilant. So they might look at your face, Sarah, and they may read that as an angry face. They're very, sensitive to that. But when you look at those same kids when they're 12 or 14 and you put them into a stressful situation, there's actually no stress response. Like they're emotionally, they're just flat. Right. So it does
Interesting.
have a very lasting long-term impact.
Okay, great. We have a few more questions in the chat pod or in the Q&A pod. So as a dietitian, I see intersections with feeding skills and supporting parent feeding concerns, as well as addressing household food insecurity, but see a gap in access to dietitian support in the community and limited access within public health. If you
Yeah.
have any experience with this, can you comment on your perspective?
Yeah, well, I can tell you that one of the ways that infants express even just their challenges. Developmental risk is around feeding, and it can often become a real battleground for parents and for children. I mean, even with my own daughter, I can still remember her. She's still angry because her father would make her eat fruit after a meal, right? And she's just like, my husband comes from a culture where you finish every last bit on your plate. You just don't, not eat what's given to you. And to this day, she'll still like, she will not eat apples. So these things do stay with us. And I think it's really hard for families to know, who do I talk to about this? So part of the challenge with pathways is that we really need to be able to help families get to the right service in a good amount of time. And can you imagine for the family where feeding is an issue and they're sent to, I'm exaggerating to make the point, so please don't take this literally. They're sent to a food bank, right? Well, that's a service, but it's the wrong service. It wasn't about food security. So I would encourage dietitians to really connect with those partners in their community, to even let them know, how would families find you where you are. I don't think that is obvious. And often when we begin the pathways work and we do a bit of an environmental scan, we're surprised and not surprised at the number of people who will say, even in places like Toronto, I had no idea that service was around the corner from our office. People don't know what's out there.
Yeah, that's very true. Okay, for the next question, for health providers looking to develop their knowledge and confidence in this area, are there trainings you would recommend?
Yeah, I think there's so first of all, we have a free I don't know, a couple of hours. You can, listen and stop and listen and stop. Really basic introduction, and it's free. There's no charge for that. We have lots of other training that sits on our website. So when I look at the upcoming year, I know we're doing a session. I don't know if you guys have heard anything about this, you folks, but infant sleep, big hot topic out there, and lots of misinformation being conveyed through social media that parents are paying attention to. So we have a session on the art of infant sleep. We have Dr. Rob Meter presenting on kids who require more complex care and their mental health. We have somebody who's going to focus on intimate partner violence, another session on trauma. We also have the lecture series, which public health units have free access to because the province paid for that. And you won't want to watch all 15 sessions. I can tell you that right now, and you don't have time for it. But there are particular sessions that may be of general interest to you. So if you need a reminder about how to log into that system so that you can share that with your team, let me know, and I'll put you in touch with Nikki and on my team who can share access, and that is free. It's paid for. So those are just a few of the things that are, and I always think, the free stuff is really important because I don't want money to be a barrier to accessing the information.
Yeah,
And
absolutely.
and just so people know, so we do charge, and the reason that we charge is because AMP is an unfunded program within the hospital for sick kids. And so we are entirely dependent on external funds. So I spend a lot of my time searching for money, and that money is what pays staff salaries and buys computers and all that kind of thing. So that's the only reason that we have to charge. But if I had my way, I would win the lottery tomorrow and I would set up a trust for AMP, and we would make everything free because that's how important the information is.
Yeah. Okay, excellent. Thank you. Our next question is there any talk of implementing a provincial surveillance system? It would give us a much better picture of the infant and early mental health in the long run. How do we start that conversation?
I mean, we've started it, so you're welcome to join us for the conversation. We are talking with the province as well, and I'm actually getting ready to submit a proposal to them. And I think this is part of why we need the meeting on November 20th. to see how do we move this forward. I do think public health has a really important role to play. And I will also say there, there was some time ago, before the pandemic, some statements that suggested that developmental screening or universal screening, there was no known benefits. The science has really changed on this, and even the World Health Organization has clearly stated that there are benefits to universal developmental screening. And there are parts of the world less resourced than us that have actually implemented developmental surveillance for this age group.
Yeah, there is, I mean, just to clarify, the Canadian Task Force on Preventive Healthcare did put out their statement in 2016 saying that they did not recommend for universal developmental screening. However, their science is changing on that, I believe,
Yeah.
and uh, a lot of families that come across public health actually would qualify as a high risk family if they're coming to seek care anyway, or seeking advice on a developmental concern. So in fact, there is a role for public health to screen, I believe.
Yeah.
And just to plug my own product, there is going to be a focus on early childhood developmental surveillance and screening in Ontario Public Health Unit product coming out, I believe, in 2 days. So keep your eyes on the communications from PHO, because you'll be getting a link to that product, and it kind of goes over the current state of developmental surveillance and public health. That's a really good, I think, jumping off point to having more of these conversations within the context of what current policies are. We do in Ontario have an enhanced well baby visit that does recommend surveillance at 18 months. So that is a pretty intense, policy and paid thing that primary care does. So we are trying, but it is a huge area that I think, as you've rightly pointed out, could use some more focus, especially from the province.
Definitely.
We have one more quick question.
Mhm.
What would you suspect being would be the largest difference between licensed childcare and licensed home care that could be affecting the changes in child development that you saw?
So I will admit to you that my early days were I started in childcare, and I ran one of the first workplace childcare centers at the Ministry of Transportation. Um, so in a center-based setting, there are you have colleagues, and you have people that you can turn to when you don't know the answer, when you've got an idea or you want to observe a child because you think you're seeing something. There's a community there, and I think for licensed home childcare providers, it can be a pretty isolating job in some ways. And I consider myself a pretty, I don't know if my kids would agree. I thought I was a reasonably competent parent. But the idea of caring for 5 children is a bit overwhelming. And that's the kind of number. They're not all the same. You can't have 5 babies. They're different ages, but I think it is isolating. I think also we can't ignore the fact that early childhood educators in childcare centers have 2 years of formal training, um, and licensed home child care providers may not have any training at all. So there's training, opportunities given to them, but there isn't a requirement to when you decide to become a licensed home-based childcare. So those are just some of the differences. Yeah.
Great, thank you. So as we wrap up today's PHO rounds, I'd like to thank you, Chaya Kulkarni, for presenting. I'd also like to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this and to help us improve our programming. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.